My name is Greg Szto. I'm a Director of Cardiology at Peninsula Private Hospital, and I've been working here for the last 22 years in the Mornington Peninsula area. I came here in the middle of 2000 and helped establish the cardiac cath lab here in the year 2003, and also introduced a lot of other heart-related treatment programs here, such as open heart surgery in 2012, structural heart disease treatment such as Watchman in 2014, transcatheter aortic valve implantation in 2016, and subsequently other structural heart, hole in the heart treatment, as well as lately mitral clip. I've also been director here for the last 20 years or so to help direct and spearhead any programs that may improve the treatment of patients from the heart point of view in this community. A structural heart disease involves valve problems, holes in the heart, or other things of a structural nature that requires either stents or devices to help close holes or seal punctures, etc. For example, when we discuss structural heart disease, that would encompass procedures such as a Watchman device to seal the left atrial appendage, transcatheter aortic valve implantation to help with people with severe aortic stenosis, and then lately the mitral clip procedure, which is a clip placed in the mitral valve to help treat patients with severe mitral regurgitation. Structural heart disease treatment is typically provided by cardiologists who are trained in interventions, doctors who do stents, and then have additional expertise in other procedures such as Watchman, TAVI, and mitral clip. So on top of their usual training in coronary stenting, rotablator, intravascular ultrasound, and fractional flow reserve, they now add to that base additional skill set that helps treat patients with structural heart disease. In Australia, structural heart disease treatment needs to be credentialed on top of the usual qualification. So the doctors who do these procedures are typically licensed by the government to provide these services in special hospitals who are credentialed and qualified to provide those services. And I can proudly say that Peninsula Private Hospital is one of the most advanced hospitals that are able to provide these services locally instead of patients needing to go up to, say, Monash or the Alfred Hospital for their treatment. So we have been able to bring this technology to the local area so that the patients can receive their treatment locally. When patients have atrial fibrillation, they have a higher risk of developing a stroke. And the main reason for them having a stroke is because there is a higher risk of clots forming in the left atrial appendage. When that happens, and for some reason, if the patient is not on a blood thinner, then there's a higher risk of the clot forming in the first instance, and secondly, embolizing, say, to the brain to cause loss of circulation and a stroke. Now, not all patients with atrial fibrillation can put up with taking a blood thinner. And because of that, they are at an increased risk of a stroke. There are various reasons why a patient may not be able to take a blood thinner, such as apixaban, rivaroxaban, or dabigatran. And in those circumstances, cases such as nosebleeds, multiple falls, and brain bleeding, for example, skin bleeding, or hemorrhage into the gut for whatever reason, rectal bleeding, hematuria, are potential reasons why patients may not be able to tolerate taking anticoagulation long term. There are some patients who are also having drug reactions or interactions with the blood thinners themselves. So we also know that 90% of the clots that form in the heart that can go on to cause a stroke in patients with atrial fibrillation are residing in the left atrial appendage. And so we've come up with this concept of closing the left atrial appendage or occluding it from the regular circulation so that we can reduce the risk of the patient developing a clot and having it embolized to cause a stroke in 90% of the time. So once the patient has had a Watchman device inserted to close the left atrial appendage, they don't need to be taking blood thinners. They can just take aspirin 100 milligrams daily, for example, and still not be exposed to a higher risk of a stroke. So in your practice, when you look at your patients with atrial fibrillation who are on blood thinners, those patients who may be suitable for these procedures include the frail elderly patients who may be prone to falls and endangering themselves with bleeding in the brain or in the joints or in the soft tissue areas when they have a fall, or those patients who for whatever reason have bleeding problems. And that would include patients who have epistaxis, GI bleed, hematuria, and other joint bleeds, for example. So these are the patients in your practice who may be suitable to have this procedure, who act as an alternative to taking blood thinners. So what I'm holding in my hand is a Watchman device. The Watchman, as it is in my hand, is already expanded. But before it goes into the person's left atrial appendage, it is actually compressed into a small catheter that is introduced from usually the right femoral vein, advanced to the right atrium, and through a small puncture in the septum, advanced into the left atrial appendage. And then when the catheter is at the mouth of the left atrial appendage, I will then retrieve the catheter and push this device out to seal the opening of the left atrial appendage. There are different sizes of the Watchman device for patients with different anatomy. This Watchman device is a very safe procedure and takes approximately half an hour to do, and is done under general anesthetic with inclusion of a transesophageal echo to guide me as to where to place the device and to determine whether it is safe to deploy it. Once we have identified a patient who may be suitable for this Watchman procedure, we will organize tests to check the anatomy of the left atrial appendage. This test may include a CT aortogram to look at the anatomy and size of the left atrial appendage opening. And sometimes, if the patient can't have a CT scan, we may organize a transesophageal echocardiogram, which may also assess the anatomy of the left atrial appendage. The procedure involves inserting a catheter from the right groin up through the inferior vena cava into the right atrium, and then we make a puncture through the septum for the catheter to go over to the left atrial appendage. So the potential risks of the procedure involve puncturing either the heart here or the lining of the left atrial appendage. The risk of that occurring is less than 1%. Sometimes we have to manipulate the catheter quite aggressively in the appendage to try and get the right direction, and that can sometimes cause perforation as well. That is the major complication of the procedure, but it occurs in less than 1 in 100 cases. The other thing that can happen is that the Watchman may slip off and embolize. It has never happened in my own experience of over 330 cases, and I've done the most of this in Australia. However, in experienced hands, it can be an issue if it is not sized correctly. For example, I have a patient who had a subarachnoid hemorrhage, and in that situation, it would be a bit dangerous to put the patient back on a blood thinner. So in that patient situation, we decided to proceed with insertion of a Watchman device. After the insertion of a Watchman device, the patient's risk of getting a stroke in a setting of atrial fibrillation is reduced by the patient taking aspirin only as compared to the patient continuing to take a blood thinner. The benefits of a Watchman procedure is to allow the patient to continue without needing to take a blood thinner with atrial fibrillation, but with the Watchman acting as a protector against a stroke. There are some patients who you may think about starting them on a NOAC, but they may not be appropriate because you're concerned about them falling about, say because they've got Parkinson's or they're quite frail. And in that situation, sometimes we consider the Watchman as the primary stroke prevention option compared to starting them on a NOAC therapy. You can refer the patient directly to a cardiologist who performs this procedure so that we can work the patient up to determine their suitability. A lot of patients are referred to me through other specialist colleagues such as a gastroenterologist if the patient has a GI bleed, or a urologist if they have hematuria, or from an ENT surgeon or emergency room specialist if they present with epistaxis or a fall, or they have broken bones and bleeding, or suprarenal hemorrhage. And so sometimes I get referrals from neurologists and neurosurgeons as well. If you have identified a patient who may be suitable for a Watchman procedure, all you have to do is refer the patient to our practice or to a cardiologist who does Watchman procedures in your locality, and we will evaluate the patient for suitability to check to make sure that they are appropriate for the procedure.